Morning, everybody, and welcome to Grand Rounds. Next week, our Grand Rounds speaker will be a Columbia faculty member, Wendy Chung, who's a pediatrician, but more notably a leading geneticist, and particularly in neurodevelopmental disorders. She'll be talking about genetic insights into autism and related neurodevelopmental conditions. We have, I think, some resident applicants who are attending Grand Rounds, so welcome. And during the discussion, if you have any questions, feel free to ask them. It's a very supportive crowd. Nobody will laugh or make you feel like you're asking something that's stupid or something. And let's see, do we have any other announcements today? No. It's a kind of special occasion to introduce our speaker today, who's Dr. Julio Licinio, because of the fact that many of us have known and worked with Julio in various capacities over the past, maybe 3 decades. And in part, it's because of the fact that Julio's work has been very seminal and really kind of at the forefront of research methodology. He was really kind of an early adopter of genetics before it became like the new thing. Also, because of the fact that he was a founding editor of 3 Nature journals. You're not doing 3 now, you're just doing molecular psychiatry. You're doing all 3? Molecular psychiatry, translational psychiatry, and pharmacogenomics. As you submit papers to these journals, you develop a relationship with the editor of some sort. And then the third thing is because he's as peripatetic as any one of our colleagues as you'll ever meet, and you'll understand why I say that in a minute. So Julio is a native of Minas Gerais in Brazil. He received his medical degree at the University of Bahia School of Medicine in Salvador, Bahia. He then did his residency in internal medicine at the University of Sao Paulo, and then came to the United States, where he did a fellowship in endocrinology at the University of Chicago, then an internship at Albert Einstein, and then a residency in psychiatry in the research track at Cornell, where his mentor was the late, great Jerry Klerman. He then moved up to Yale, where he was a junior faculty member, and then from Yale to the NIH, where he was in the intramural program. He was the chief of the unit of clinical research, clinical neuroendocrinology, working with another mentor, Phil Gold, and then migrated west to UCLA, where he rose to the rank of professor of psychiatry and became head of a number of programs, including vice chair in the department. And there he was working really with Barbara Levy, Peter Wybrow, and began to sort of apply his interest in metabolism, nutritional biology, and genetics. From UCLA, he then moved to Miami, where he was professor and chairman at the now Miller School of Medicine at the University of Miami. And then in 2009, made the big move to Australia, where initially he was director and professor of the John Curtin School of Medical Research in Canberra, and then subsequently as the Matthew Flinders Distinguished Professor at Flinders University in Adelaide, Australia. Now, we didn't bring him all the way from Australia today. 9 months ago, he took the position of being dean and senior vice president for academic and health affairs at SUNY Upstate in Syracuse. So he's now a New Yorker like the rest of us, and is the dean of one of the state universities. But despite that, he's still active academically in his areas of interest with the journals he's working on. He maintains some research role, although it's a lot more administration than before. And among the areas that he studied, he's now sort of merged an interest in the issue of obesity and nutritional metabolism, and psychiatric disorders, in this case, depression. So it's a pleasure to welcome Julio back to the United States, to New York, and to PI in Columbia today to give grand rounds. Please give him a hearty welcome.
Thank you, Jeff. It's really wonderful to be here and to talk about my work at the interface of metabolism and mood and depression. I'm going to do one thing because I think there is a glitch with this program here. I'm going to quit it and restart because I did a test run before and it was a little funky. So let me do it again here. Yeah, it's here. Open. Yes. Okay, so thank you. I'm really delighted to have this opportunity. One thing before I began is that I trained initially, as Jeff mentioned, in endocrinology, metabolism, and diabetes specifically, which happens a lot in the context of obesity. And then I trained in psychiatry. And these are two very common and complex disorders that very often interface. And I think because the interface, you really have to look at them together. And I cannot tell you how many grants I've applied for and how many proposals I've put that I looked at them together. And people say, you know, this looking at both is really distracting. I always remember this comment from a pink sheet from a study section. Oh, one is distracting from the other. Why don't you just study one and then you can do something else with the other later? But it's like, hello, the person comes and they have both conditions, and you know, the cytokines that are characteristic of obesity, and obesity is a hyperimmune state. The cytokines are making your depression worse. The depression is, you know, making you spend less energy and eat more food and making your obesity worse. And it's like one, you know, kind of cascade in the same person. And people who are truly experts in the field say, no, don't look at these things together. Look at the metabolism there and you know, do a metabolic study and then do a mood study separate. And so that's been like an issue for me my whole life to persuade people why you need. I actually had a slide. I don't put this together anymore, but I had a slide like 10 reasons why you should study these two things together. And then, which the reasons are very, you know, kind of compelling to me. And then I've had reviewers write back and say, these reasons are really flawed. The first reason, it's flawed because of this. The second reason, it's flawed because of that. But people have like a very strong resistance to looking at things. Let me turn my alarms off. At looking at things, you know, together as one thing, which they are. So here are my collaborators. Just 1 second. Hold on 1 second here. This is not the slides that I had lectures. It is this. Yeah, it is okay. Just 1 second here. Yeah, it is the one. I think so. Just do one thing that I can tell. Just a second. I may have the wrong file. I'm sorry about this, but better to identify the right file now than later. So, no, it is the right file. Yeah, it's all here. So here are my collaborators in different institutions. We just arrived at Upstate, so I don't have a lot of new programs going on there. And one thing that I really would like to focus here is the issue of a translation and a translational gap. So why aren't current treatment of depression based on the immense neuroscience discoveries of the last 40 years? If you treat any psychiatric disorder today, like, you know, in a clinic, in a regular clinic, not a research program, the treatments that people get are based on ideas that are at best 50 years old, 60 years old, 40 years old, and nothing that has been discovered in the last 40 years has made it into routine clinical care these days, which is highly problematic. So I work with my wife, Professor Mali Wong, so we at the same age, went to the same institutions. I actually met at work at the University of São Paulo so many years ago, and we studied the same things. So she has a different take than I do, and I think that that's what makes the work, I think, a little deeper and richer than it would otherwise be. So we had this paper that has been very highly cited, and its time keeps passing. So I've been invited to write an update. So this is 16 years old, and what we put together back then is that for depression, you would have genetic factors, and I put a small box, which I call susceptibility genes of major effect, which probably this box would be very tiny. Now it's very unlikely that there are such genes. And at the time, I put this box, which I thought would be much bigger, that would be susceptibility genes of small effect. And then you have environmental factors going all the way from the prenatal period all the way to old age, and resulting in depressive syndromes. And this plural here was very deliberate, and that as to denote the heterogeneity of depression. So our key concept is that obesity is far more intertwined with depression than appreciated. So are they both, is depression a cause or outcome of obesity? Are they both caused by a chronically dysregulated stress response? What about the impact of antidepressants? And obesity is tightly related to the medical outcomes of depression. Then there are what I call misunderstood candidate systems, including stress-related neuropeptides and immune mediators that I've been working on for over 30 years, and pharmacogenomics and genomics, and which represent new approaches to old problems. And so if you think about chronic stress, stress is, can, in different people, result in very different pathology or psychopathology. So in some people, when they are chronically stressed, they have an autoimmune disorder. A next person will have either precipitate or worsen their bipolar disorder, or will cause PTSD, will precipitate or worsen or cause metabolic syndrome. So you have these multiple manifestations of stress in different situations. So the stress response really evolved for the organism to deal with something like that. So yes, that gazelle is very stressed, and there will be two outcomes for that gazelle. It will either die very quickly, or it will survive. And then if it survives, it will be in a quiet place. It will not be undergoing this forever. And today in the workplace, this is the gazelle and this is the cheetah. And then it's a very different environment than what we were evolved to deal with, which was acute stress. So in the context of chronic stress, you have chronic activation of neuroendocrine and neuroimmune systems, which result in, for some people, they overeat, and that overeating, in a way, and you'll see through the lecture, kind of self-treats the depression. So you have people who are non-depressed obese. In some people, they overeat, but it doesn't work out so well, so they are depressed and obese. And some people actually have activation of anorectic pathways, so instead of eating, they do the opposite, and they become depressed and lean. So obesity has been described since antiquity. However, the rate of obesity is escalating in recent years. And what I'm going to show you next is probably the most shocking and amazing data set that exists out there. So these are the rates of obesity in the United States. And it was a survey done by the CDC that began in '85, and at that point, they didn't have data for all the states. So the states that they didn't have data for are in white. And you see the white will decrease over the years because, you get data from progressively more states until you have data for all the states in the country. And I'll be passing these slides quickly so you can see the difference and to save time as well. But you see it more effectively if I go quickly. So before I go through them, note that that's BMI over 30. That's the metabolic definition of obesity. And you see that some states, less than 10% of the population was obese. In other words, over 90% of the population was not obese. And other states was 10 to 14%. And this is not decades, one decade after the other. It's like 1 year after the other. It's like, this goes really fast. I've never seen anything happen so fast in terms of in medicine ever. So this is 86, 87, 88, 89, 90, 91. A new category had to be created, 15 to 19% of the population of the state obese. And you see that the light blue is decreasing, and the white is disappearing because you get data for everybody. So here, the light blue has disappeared. No, here has disappeared completely. And we have data for all the states. So that's 94, 95, 96, 7. A new category had to be created. More than 20% of the population of the entire state obese. And that's 97, 98, 99. And people say, oh, it's the fast food. But I don't think that the rate of increase of, franchise of McDonald's is opening, and changing like this quickly, people's eating habits. But anyway, so 2001, a new category had to be created, 25% to 29% of the entire state obese. And you see that Colorado is the healthiest state in the U.S., so it's the last holdout of that 10 to 14% category, but not any longer. So 2002 and 3 and 4 and 5, a new category, more than 30% of the population of the state obese. And you see that darker blue is disappearing. So it was only 2 states, now it's 3, and then Colorado is still the healthiest. And now more than 30% is growing and is taking over. And then Colorado succumbs, and then and then they had to change the colors because you couldn't make the red any darker, and there was no blue anymore. So that's, and then they predicted, Mississippi at the time when this slide was made was 34.9% of the population was obese. So they said, oh, let's put a category for over 35% because it's going to happen soon. And then it didn't happen the next year, 2012, and then it happened. Mississippi and West Virginia, that's 13, and then this is 14, and that's 15 now, 4 states, with more than 1/3 of the population of the state clinically obese. So this is very drastic. And the rate of obesity is escalating in recent years. Are chronic stress and other factors that act in conjunction with stresses increasing in recent years? Because I thought, what is this? Is there anything psychological to this? So is stress increasing? So there is this survey from the other, as I call it, the other APA. So Jeff was the president of our APA, and there's another APA for the psychologists, which I'm sure there are many in the room. That's your APA, so which is the American Psychological Association. That actually, because they are more tech savvy than the psychiatrists, they got APA.org is the American Psychological. The American Psychiatric was too slow. So, yeah, well, yeah. So, but anyway, so they did this survey, which is kind of very messy because they looked at rates of stress beginning 2012, look at the previous 5 years, but there was the global financial crisis was in the middle of this. So, what's happening, it's complicated, but you see that even in 12, things have recovered a lot. The economy had recovered a lot compared to the peak of the financial crisis. So in spite of the economy doing better, many more people reported increased stress than decreased. And what I find relevant is that it's very easy to say in a psychological survey, oh, yes, I'm stressed. But then if you try to get like the details, how many people lay awake at night because they're so stressed they can't sleep? 44% national, caregivers 60%. It's very high. And then people who overeat because they're stressed, 39%. People who skipped meals because they're stressed, 29%, and caregivers is always higher. So if you look at the overall stress rate in the population, it's 5.3. With depression, it's higher. With obesity, it's higher. And the combination, they didn't look because nobody looks at the combination, but I would imagine it would be higher than even the two together. So in Australia, where I was for the last 8 years, there is a lot of work. They're very good at population studies. So there is a survey in the city that I lived last in Adelaide that goes, it's a household survey, so it's a community-based survey. So it's not like a bias because of referral sources. And you can pay a certain amount, and then if you pay, your questions are included in the survey, in the community-based survey. So they begin with 5,000 people, and they usually get 3,000 people who agree to respond. But you literally you knock on the doors, and it's very well designed. So it's like, It's not biased towards one population or one group or one socioeconomic, demographic. So, so we put some questions on antidepressant use, bullying, and sexual abuse. And when I left, we had just obtained the raw data, which is still being analyzed. So I was actually shocked at the rate of bullying. So 45% of the population reports having been bullied, including adult bullying at work. Sexual abuse, 9%, which is high. And we are looking at the effects of antidepressant exposure on body weight. But I'll get back to this later. So how do people cope with increased chronic stress and depression? They take antidepressants. So I published this paper 10 years ago showing that as the rates of prescription of fluoxetine, which I took as a proxy for antidepressant use, went up, which was being discussed a lot at the time, there was a positive outcome then, which is that suicide was coming down, which is not exactly the case now, but that was what, based on the data that I had then. But this data from the UK, I think is very revealing because it shows antidepressant use from 98 to 2010. And you can see here that this is all antidepressants. The number of prescriptions goes up 3.5-fold over this 12-year period. So, and you can see that from year to year, from this is like 88, 89, 2000, so each data point is 1 year. So every 1 year, you have this drastic increases in prescription of antidepressant, which is significant enough. But there is one factor here that's not kind of people don't treasure. There are a lot of empty seats here. If you guys want to come and sit, it doesn't disrupt. So just come over. You don't have to stand up for an hour. Please come over, yes. So this is from the CDC. 11% of Americans aged 12 years and over take antidepressants. And in Australia, which the rate of antidepressant per population is higher, it's I think it's 12%, no, it's 11.6% of the entire population. So in Australia and Sweden, depression is the #1 cause of disability, of disease burden. In the States, it's #2. There, it's #1. So one thing which you have to think about antidepressants is this. If you saw the rates of prescription going up, and it's like this everywhere. So you see those numbers going up. People, this study here is representative, but I've looked a lot into this literature. It's the case. Here it says that 50% of this one large study in Europe, who with over 7,000 people who started on antidepressants, stopped within 4 months. So they had the prescriptions renewed, so they were taking them, and then they stopped without doctor intervention. So you saw the rates of prescription going up. So for the prescriptions to go up that much, and for about half of the people to be stopped taking them by themselves, it was the same number of people, the prescriptions would be going down. So for what you saw to be happening, the same number that's stopping, an equivalent number should be starting, so it would be flat, and plus more. So, so the population exposed shifts over time. So some people take antidepressants, they stop. Then an equivalent number of people, and higher than that, like a higher number than the equivalent of the ones who stopped, starts. And then the next year, if you look year by year, the next year, a substantial number stopped, and then a number that's that number plus additional people then start. So if you look over time, the population exposed is very high. And I've actually looked in many databases and talked to many people who do this type of work. You can't account for it because it's not asked. People are not asked, like, did you take antidepressants ever in your life, and when did you stop them? The question is not asked in surveys. So I think we severely underestimate the effects of antidepressant exposure. And I've seen clinically, and that's why I engaged in this whole study that I'll be showing you next. You see clinically people who you start on antidepressants, then they may stop, and then they begin to gain weight, and they keep gaining weight, and they are heavier forever than they were before you put them on the antidepressants, even though they're no longer on the drugs. So, so this is the situation. So is there an effect, a long-lasting effect of antidepressant exposure? So our current clinical situation is that we have a baseline of an obesogenic food environment. You have chronic stress with high cortisol levels out there. You have increased and earlier onset of depression. And one thing which Jerry Klarman always told me multiple times that he found in his studies that I think is remarkable is that when you have genetic-based depression, genetic depression that happens in families, there is this phenomenon that each generation, the phenotypes comes earlier. So let's say if the great-grandfather was depressed, killed himself or something, that depression came up in their 50s. The grandfather, like 40, he was depressed. The father was depressed in their 30s, and the current person is in college, or early adolescence. So at each generation, you have it coming earlier. And so you have widespread escalating antidepressant use. So what are the metabolic consequences of this combination? I thought it was kind of unethical to test that experimentally in people and very messy too, because you're not going to, give antidepressants to people, then stress the hell out of them, and then give an obesogenic diet on purpose for a long time and then see what happens. So we developed a new animal paradigm to test exactly that. So, so in the animal paradigm, we give short-term stress, chronic stress over a period of weeks, then short-term exposure to antidepressants. And we've done with all of our models, we did this study in Miami, in Canberra, in Adelaide, and we get the exact same results. So this is very reproducible in our hands, at least. And then we stop everything, so there's no stress, there is no antidepressant, and then we give the animal an obesogenic high-fat diet for close to a year. And so that's expensive to do. And 295 days. So here's the paradigm. And so when you give when you cause the chronic stress, the animal behaves depressed. So yes, you have a sucrose preference. This is chronic restraint stress. They are less hedonic, so they're more depressed. The latency to feed is higher. The number of marbles buried is higher. Then when you treat with a fluoxetine at the same time, or imipramine, it decreases. The behaviors are reconstituted. And this is what I think is probably the most remarkable finding of my career. It's something simple, but it is amazing. So you look at body weight. So this is both animals were, stressed and then put on the obesogenic diet. So they're not on a regular diet. They're on a high-fat diet. And these animals never had antidepressant. And these animals had fluoxetine. That stopped, here. It stopped like in a month. And then 10 months later to 11 months later, here they are, weight-wise. So the exposure to antidepressants can cause delayed weight gain in the context of an obesogenic environment. And I studied leptin a lot in my life. I'll be talking about it. It's not leptin. There is a hint it may be IGF-1. And one of the theories for antidepressant effects is that it's stimulating growth factors in the brain. So I've been thinking, well, is it stimulating growth factors only in the brain and promoting adult neurogenesis, or is it stimulating growth all over the body? So I think that's the case. So we are now doing studies that we're measuring growth hormone rhythms in those animals, and we are doing characterization of this model. And my wife got the grant in Australia that's still, in effect, to study this. So our current situation is that you have obesity and depression, and then you add antidepressants, and you have that. So could this be a contributing factor to our current obesity pandemic? So I worked with I've been, trying to investigate this if it's happening at the human level for many years, but I finally found a group in Australia that had a 4-year follow-up. It was a 5-year follow-up, but the best data was from that was cleanest was from a 4-year interval. So we looked at that, and they had antidepressant use. They had type of diet. They had weight gain. They had everything that I would need for the study. Coincidentally, they had collected it independently, and then we analyzed it for this, and was just came out a few months ago. So it's 2,000 people. Here are the ages, 50 years. And so here's essentially the demographics. So some people had depressed, some had been on antidepressants. So it's about 200-something people on antidepressants here. Yeah, so known users, the majority, one or two prescriptions is 188, more than two prescriptions, 212, and the types of antidepressant. But what's very interesting is that I predicted this before the study, and it's very interesting to see what prediction comes true, is that if you are on a Western dietary pattern, so like junk food essentially, if you have low intake of junk food, and you take, let's say, more than two prescriptions of antidepressants a year, but you are on low junk food, so you eat a healthier diet, you don't gain the weight. You gain like, 0.1 kilos for the period here, per year. But if you are on a high intake of junk food and take the antidepressants, you gain additional weight more than you would otherwise gain from just the diet, this 0.8 kilos, which is essentially 2 pounds a year. But then you multiply that by 5 years, it's 10 pounds. So it's a lot. And so, so the conclusion that we had is that antidepressant use or exposure facilitates, potentiates the negative effects of Western diet. So, so the conclusion here is that there is weight gain after termination of drug use plus ongoing high-fat diet. And in animal studies, I didn't even do the studies because you can see that 10 months, animal costs are very high. But actually, initially, fluoxetine was even proposed based on animal studies should be a weight suppressant because the animals don't eat that much. But rat chow is not very appetizing. So for them to overeat that to the point that they would become obese would have to be a very strong stimulus. And I was thinking of something more subtle. That's why we put the obesogenic diet. So exposure to antidepressants, and that word is very crucial, exposure, not necessarily treatment, leads to long-term weight gain with high-fat diet. The molecular mechanisms need to be elucidated, and we are studying that. So at the population level, antidepressants potentiate the weight-gaining effect of Western diet. So think about how bad, junk food is. And if you have been exposed to antidepressants, junk food is even worse for you. And you're more likely to be susceptible to its bad effects than if you had never had that exposure. So antidepressants are the second best-selling drug class in the U.S., and the number one are analgesics, which include over-the-counter medication. There's no antidepressants over-the-counter. So of prescribed medications, antidepressants are the number one best-selling drug class in the whole country. And is lifetime antidepressant exposure a contributor to the obesity epidemic? And when I present this data and have, there have been press releases before and talk to people, people say, oh, so you should not use antidepressants. No, I think you should use them if you're depressed and the disease is pretty serious and suicide is a potential outcome and it's the number one cause of disease burden in Australia, number two in the US. No, yes, you should take it. But you saw that you don't gain weight with a healthy diet. So there should be a very kind of effective, preventive, and weight, you may know, if once you gain, you don't lose it. It's very hard to lose weight. So do we do what we need to do to prevent weight gain on people that we first prescribe antidepressants? I don't think we do any education or any warning even. And I think that that's where we could make a difference. So if you look at the spectrum of gene-environmental interactions in obesity, I mean, I came up with this myself, so I can think of three situations. One is that you have a predominance of nutritional environment. So no matter what lean genes you have or how predisposed you are to obesity, if you eat like this gentleman and you eat a lot of it, one day you will gain weight. And then these are people in which there is predominance of psychological environments. And for other people, there's a predominance of genetic factors. So, and that's how I'm going to go for the rest of the talk. When you study, and I've studied these both conditions, there is a huge advantage to studying obesity is that you have genes of major effect. So once you have a gene of major effect that causes the disease, even if it's very rare, you identify a pathway, you identify a hormone, you identify neurotransmitters in the brain related to that, and you can really unravel the whole biology of the disease. And if you don't have genes of major effect, it's very hard to do that, which is the case of depression. So in obesity, you have this. So these are inbred mice, and this is a classical paper from 1950. So these are from the same, they're littermates from the same parents. This mouse was like this, and then once it grew, became like that. So it's obvious that this mouse has a genetic defect that predisposes, and it segregates, genetically. It's a classical Mendelian inheritance. So you see that there is a Mendelian inherited, gene of major effect that regulates weight. So one of the first achievements in positional cloning was the discovery by Jeff Friedman's group at Rockefeller University that what was the problem with that mouse was that it lacked new hormone, so the genetic effect was pinpointed to a missense mutation in a hormone that had not been discovered. So in the process of doing that, they discovered the hormone because the mutation was in a new gene, and the gene encoded a protein that people didn't know existed. And so that protein was called leptin, for the Greek leptos for thin. And it has two actions. It simultaneously decreases food intake and increases energy expenditure. So it's like a double whammy to reduce body weight. So it sends a signal to the brain that the animal has enough food and should stop eating. So what can we learn from the actions of obesity genes of major effect on human brain and cognition? So leptin was one of them. There were many others that have been identified in the same manner. So there is a Gucci-related protein, the MC4R, a receptor, alpha-MSH, AGRP, POMC. So because of these different mutations, then the biology of each substance is identified and unraveled. And then you have a whole map of the neurobiology of obesity in a way that you don't have the same map for the neurobiology of depression. So the patients with leptin that you'll be seeing in a minute, there are identified in the whole world 29 people. But because of that, we have a huge advance in our understanding of what's going on. So when leptin was initially discovered, I was working at NIH and looking at biological rhythms. So I said, let me measure the biological rhythms of leptin, which the endocrinologist at the time told me there is no rhythm because it's made by fat cells. They're just oozing from the fat cell. I remember this word very well. This was Jeff Friedman. Jeff Flyer. Jeff Friedman's from Colorado. Jeff Flyer, who became dean of Harvard Medical School for 10 years. He told me that, no, Julie, there's going to be no rhythm because this is leptin is just oozing out of the adipocytes, and there's going to be no, pulses or peaks. That's what I studied at the time. So I said, well, let me measure them. So I measured, and yes, there are pulses and peaks and a circadian rhythm. So how can a product of dispersed fat cells exhibit such organized patterns of secretion? So I looked at leptin, in the blood in different situations, looking at sex differences, looking at the complexity of the dynamics and relationship to other hormones. So this is cortisol and ACTH, two stress hormones that I talked to you about before. You can see that leptin is highly inversely related to, this is not the levels, this is the percent variability from point to point. So I actually invented this measure that's now very widely used. So you look at, like, let's say I sampled people every 7 minutes for 24 hours. So you have 207 points. So if you look at so what I said, how can I capture the variability? So I invented this measure that you get the average level for the day. And then, so you put in the denominator and the numerator, you put T2 minus T1. So let's say if at, 9:07, the value was 12, and at, 9 o'clock it was 10, then you put 2. And then you have 2 divided by the average and multiplied by 100. So it gives you a percentage of how much the levels varied from one time point to the other in the context of the person's overall average. So that's a very precise measure. And from point to point through the day, through the 24 hours, there is this very precise inverse relationship, which is highly significant between the variability of ACTH and that of leptin. So the two things are pulsating together in an inverse way. So then if you look at TSH and leptin, you don't even have to do that because the rhythms are essentially superimposable. So the more transformation you do, and here, and if you see, this is the log. So when you have to put on the logarithm scale and this, transformation, it's because the relationship is there, but it's not so obvious. But this relationship is so obvious, you don't have to use a logarithm scale, and you don't have to develop a new metric. So, so as I did this type of work, people would say so many years ago, oh, this is not mechanistic. You're just showing, association. One thing goes up, the other thing goes down, etc. But I'll say so many. Do you know what I feel like now looking back? Like the climate scientist, because it's an association, but you cannot do causal, you're not going to burn the planet to see if it gets warmer, So anyway, we start a nuclear war to say what the effect's going to have on the climate. So you do this very, complicated associations, but, well, the climate people celebrated. I was trashed. So anyway, so I was told, no, it's not mechanistic. It's just a pure association, and you have to show cause and effect. And I kept scratching my head. How can I show cause and effect? Then in Turkey, endocrinologist published a letter in Nature Genetics identifying a family with a leptin gene mutation. So I contacted him, and then I spent a month there studying them. So here they are when I first met them. And here's the pedigree. And think about this bottom of the pedigree here. The youngest generation has not had children yet, so I'll get back to that in a second. And so in the pedigree, for the adult man, you see that the parents, it's a highly consanguineous pedigree. The parents are heterozygous. You have this man here, that's the obese man that you'll be hearing more about. So he got the two defective copies of the gene from the father and the mother. And his brother, he has a bunch of heterozygous, siblings, but this brother here got the two good copies. So he has a brother completely wild type, and he's, completely affected. So this is the wild type brother, leptin and TSH. And this is the affected gentleman with leptin essentially barely measurable, and it's truncated. So essentially, that leptin just oozes out of the adipocytes because it doesn't have a secretory mechanism. And the TSH rhythm here, and first phase of my life I spent studying hormone rhythms. This is clearly circadian. There's no doubt. You can do mathematical analysis, but don't need any degree to say, okay, there is a circadian rhythm here. This has no circadian rhythm. This is random. This secretion is random, not organized. So in the absence of leptin, TSH loses its circadian rhythmicity. So I came back to the U.S. I got an NIH grant. I spent 2 years negotiating between Amgen and UCLA to bring these patients to the U.S. to study in the General Clinical Research Center. They came. We had a 3-month baseline of different studies that I'll be talking about in a second. Then we gave leptin, and they began to lose weight. And there was a press release when they were discharged from UCLA, and then I merged different stories from the press and made into one short little video that I'll share with you here.
These 3 Turkish cousins, Bayram, Zeynep, and Elif, may help you lose weight. Not with a new diet or exercise video, but in the world of medical research. They may hold a genetic key to the elusive mystery of weight loss. Turns out the cousins are ideal research subjects.
For all intents and purposes, it's as if their body never gets a signal that they have enough food. So from when they are born, they begin eating very voraciously, and they eat large amounts of food, and they've become very obese.
Cousins are from a village in Turkey. They flew to Los Angeles to be studied and treated by doctors at UCLA Medical Center for a rare disorder. They are the only known adults in the world with a genetic mutation preventing their bodies from producing the hormone leptin. When given daily leptin injections over 10 months, 313-pound Bayram Donsat lost 146 pounds. Elif Fakili weighed in at 231 pounds. She lost 90. And Zeynep Fakili weighed just shy of 300 pounds. She lost 93.
So every day for the past 10 months, the cousins have injected themselves with small amounts of leptin. They exercise moderately, but haven't restricted their eating. Here, Zeynep and Elif try on their old dresses. The women have each lost 90 pounds. Bayram, with his old pants, has lost almost 150 pounds.
So I think that
This is a monumental occasion. The cousins' last weigh-in before returning to Turkey, where they will continue their leptin replacement therapy. Their lives have been changed forever.
so happy, you cannot imagine. They feel very healthy, very happy. They think that they can, have a normal lifespan. And they are really very different from when they first came here.
I've never seen a case like this before. And leptin is a well-known protein, but we really haven't known sort of how to apply it in a medical sense. This family is really sort of pure science in that we know we replace it, they lose weight. Now for other people, the leptin question means, are there other proteins? Are there other enzymes? Will it interact differently? What's the role of insulin? How do the fat cells work? So it's a piece of the puzzle, but we're certainly not done yet.
Much more research must be done to determine if leptin can be an effective treatment for obesity. But for Byram, the results are unmistakable. When he flew to the U.S. last year, he needed 2 airplane seats. He's leaving in 1. Tracy Potts, NBC News, Los Angeles.
So here, patient A is the man, and here's the weight in kilos. So you can see he lost more than half of his weight. The women lost less, but they were also older, so it's difficult to say if it's an age effect or a sex effect. So we are now actually writing a paper on 15 years of leptin replacement therapy. The one on 10 years is there. And one thing which is very interesting is that these patients, they had normal blood lipids, and I had them analyzed by the best lipid laboratory in the country, and I mean the best expert, on lipids in the country. And then they also had normal blood pressure. So the obesity you see in the streets is resistant to leptin. That most people have high leptin levels, and the brain is resistant to the effects. But possibly the periphery is not. So in the obesity that you see out there, there is high levels of cardiovascular comorbidity and no infertility. And these patients, they were sexually immature, and leptin is the hormone. It's been shown by many groups that leptin is the hormone that triggers sexual development. So in anorexia, for example, once you lose a certain amount of weight, you stop menstruating, you go into amenorrhea. So that's leptin levels drop. When you gain the weight, as leptin goes up, then you ovulate. Then if leptin goes down, you stop ovulating. So in leptin deficiency, you have sexual immaturity, but you have no cardiovascular sequela. And in the obesity that we see out there, there is plenty of leptin. So you have cardiovascular sequela. So are the cardiovascular complications of obesity caused by leptin? So I was part of a consortium that studied this very intensively in Australia, and we published a paper in Cell showing that, yes, it is, and showing actually the mechanism and the location in the brain where that's happening. So at the bottom of that pedigree that I pointed out to you, nobody has died in that family. And of the people with the obese phenotype, out of 12 people, 8 died, including the girl that you saw in the picture initially. She died before we could begin the treatment. And they die of febrile illness because leptin is an immunostimulant. So without leptin, the person is immune suppressed. So we identified, so that girl died, but then we identified the boy that took another 2.5 years to bring him to the US for treatment. And I had the idea to film him eating with leptin, and got IRB consent and everything. This was after the patients, because the change was so extraordinary with the adults, but had already happened. So the boy came later. Oh, what did I do here? So I filmed him. The protocol was to film him for 10 minutes, and then I went into the film and I, micro-deleted different components. So the 10 minutes became 1. So you have 1 minute of him eating without leptin. So look at his attention, his concentration, his cognition. Look at everything that all of you are experts on in terms of the brain and focus, and how the brain is processing information. And look the focus of that brain over that meal which he chose what he wanted to eat. Then that day he began leptin treatment. So he had 1 leptin injection that evening, and then he had 10 other injections in 10 days. And then at the end of the 10 days, you'll see how his brain is processing information in the absence of any other intervention. There was no diet, no exercise, nothing, no conversation about nutrition, nothing. So you see him, and you're all experts in the brain, and look, and the mind, and look at, and the nurse at 10 minutes has to remove the fork from him and look at him and complain that the food is gone. And that's 10 days later. That's the food that he wants to eat now. The food that he had before is on the side there. And look at how his brain is processing information related to food now. And look, he doesn't look at the food at all. And before he looked only at the food. And then at 7 minutes, he wants to get out. So look at the fork. It had to be removed before at 10 minutes. Here at 7 minutes, he puts it there, and then he has a mini temper tantrum that he wants to get out. So their behavior changes. With leptin, they are much more assertive and aggressive. So, so that's the boy later, and then that's the boy later, and a few years later, a recent picture, and then one of the probably the best experience of my professional life happened when I was on my Facebook, and then I get a friend request from him, and then I check his picture, and here's his Facebook picture. And I have been providing the leptin because the companies would not provide it to Turkey. There was something with the way the government functioned there that they would not provide it to them. They had to provide it to me, and then I had to deliver it to them and monitor these people long distance for 15, 17 years. And it's been a huge drain and burden on me. Initially, for this boy, Turkey has a law that doesn't allow any type of scientific experimentation on children. And we said that this is not experimentation like insulin replacement therapy. They said, no, it's the drug's not on the market. It is experimentation. You cannot study this boy. And we're not going to send him to the U.S. So I had to, from here, organize through friends for a bill to be passed in the Turkish parliament to allow this one boy to come here. So this has been a huge, huge thing. And then with the, so I'll get to that in a second. So anyway, so you could see that leptin changes the way the brain is processing information related to food. So we got the adult patients and we brought them to the US multiple times, and then we would take them off leptin and study them in the off leptin situation. Then you can study them on, off, and on, which is very, it's the only way to study leptin because there are no antagonists. And it's not a dose, the leptin doesn't have a dose response curve. Once you get enough, you have the full effect. If you give more, you don't see anything. So at Rockefeller, they gave huge dose of leptin to healthy young men. They eat the same. Everything is the same. So it doesn't have like a typical pharmacological dose response thing. So anyway, so in the absence of leptin, you see that the insula lights up. Then at the Montreal Neurological Institute, a group did the opposite experiment, giving ghrelin, which is a hormone that stimulates food intake. And then the insula pictures are exactly the same. So in the absence of leptin when they're hungry, and in the presence of ghrelin when they're also hungry, you light up the insula the same way. And then the Mazes group showed that patients with microinfarction to the insula, they can very easily stop smoking, even if they had been addicted their whole lives. So in the insula, a lesion decreases smoking. So activation presumably facilitates smoking and addiction. So the insula is activated in the off-leptin state and in the on-ghrelin state. So is insula activity facilitating food intake and obesity, and it's a brain area that has been understudied for this purpose. So this shows that you can go from a rare single-gene phenotype to insights into brain function. And that's why I study something that only 28 people have. So does leptin change the way that the brain actually, the structure of the brain, not only its function? So we did structural MRI in collaboration with ED London at UCLA. And over the course of time, the adult patients gained brain mass. And then when you take leptin off to do these studies, the on-off studies, the brain matter decreases and then increases back once you put leptin. So it's actually, initially you thought it was long-term effect, it's actually a short-term effect. And with drastic changes in the cerebellum, which became its own paper. And so in the boy, we did very detailed neuropsychological testing, very standardized with Azarnau's group, which is one of the best groups in the country in this area. And neuropsychological testing is very robust. So let's say if I test anybody's IQ today and test it like in a couple of years, it will be the same IQ. You're not going to test today 100 and then tomorrow be 150. It doesn't happen. So, but this boy, so I thought, could it be an acute effect? So this without leptin, this is 1 week after leptin, and this is 1 year after, so to see if it's an acute or a chronic effect. And you can see that some subtypes, you have these drastic changes, which the psychologist at UCLA said that you don't see this with anything else. So, but for some tests, not for others, you see. So for some subscales, the change after 1 year is really drastic. And then just to finish this part here, a group at studying the Framingham cohort looked at rate of dementia in the population and then just stratified the population by quartile of leptin levels. So just measure 1 point leptin baseline levels, and these are the people with the lowest levels of leptin here, this broken line. Here are the highest levels of leptin and the intermediate groups. And you can see that the high levels of leptin are very protected against dementia. And because of this data and others, leptin is now in clinical, it's being planned to be put in clinical trials for Alzheimer's. So the rates of obesity are increasing in the population. This is a major public health problem in the US and the world. Leptin is a gene of major effect. It's a key regulator of brain function. When I studied endocrinology, first thing that you learn is, what's the biggest sex gland in the body? And then people, you laugh, and it's the brain. And so the brain regulates the endocrine system. But we show here that the fat regulates the brain. So it's a conceptual revolution. So leptin regulates cognition related to food. Yeah, very obvious, you saw it. But is leptin regulating cognition that's not related to food? We show that the leptin pathway is crucial for human body weight and the functioning of endocrine organs, including the brain. For time reasons, I'm not gonna, there is an investigator, actually a very good colleague of mine, Dr. Xinyu Lu, who used to be at San Antonio, now is in Augusta. And she's shown that leptin functions exactly like an antidepressant. So you give it to stressed animals, it reverses the depressed behaviors. If you knock leptin receptors out in brain areas relevant to mood, the animal becomes depressed. If you put the receptor back, the depression goes away. So she's done a lot of very sophisticated work showing that leptin regulates mood as well. And so leptin replacement reverses fully established morbid obesity. And so in most cases of obesity, you have a state of central leptin resistance. But we suggest, we are the first to suggest that leptin's effects on brain structure and function throughout the lifespan go beyond body weight and endocrine function, and it may have a role in regulating mood and cognition. So the rule in regulating mood, actually I had a patent on leptin to treat depression many years back, before Dr. Lu's work. And you can see cognition as well. So that's that young man without leptin, and then with leptin 19 years later. And we brought, I told you that I had to send leptin to Turkey, so this is the last batch that I sent from Australia. And time passed 20 years, so the patients have aged. And these are 2 Turkish doctors. And this picture is actually I think it's an amazing picture because photography is my hobby, but this is a young Turkish doctor from there, and you see the leather skirt and the minis, above the knee, and leather and tight. And these are the patients from a rural region, Islamic, and they're all Muslim, but all of them. So, but you can see that countryside women and the doctor from Ankara, very different, So, so after 19 years of pushing and pushing and pushing, the Turkish government finally approved that these patients will be provided leptin free of charge. They, develop an agreement with the company that makes it, and then they received just last month the vial, the box with their supply of leptin, so I don't have to do it anymore. So if I die, well, I was thinking, if I die, these patients will die too because it's going to give them leptin. So now I can die and they don't have to die. So, so I was so happy when I saw this. It was sent to me literally this year. It was in 2018. So what should we do with depression? We don't have any genes of major effect. We don't have any handle on the biology. So I suggest that we should examine systematically social and environmental factors and look at a candidate systems in well-characterized groups of patients. I was talking earlier with about the Amish population, the Mennonites, people who are genetic isolates. There are people in Colombia that have been studied very intensively who are from small, they're not so small anymore. Now the place are 1.5 million people, but like in a valley that had a very strong founder effect. There's the Finnish population. There are many others. Or you can go, genome-wide without the biases of a priori hypothesis. So because of the time, I'll just skip over this very quickly, and I know you guys have a lot of exposure to depression and psychiatry, so you don't need me to be going over. So I'll just give a brief historical overview of my work. So I was the first group to be funded as part of the NIH Pharmacogenetics Research Network and had the first NIH grant to look at pharmacogenetics. In other words, not the genetics of the disease, but the genetics of us, why some people respond to treatment and other people don't. So I think that actually one of the most interesting things in psychiatry, I think as interesting as the disorders themselves, is like you get someone who appears to be equally depressed as the next person, and the presentation is very similar. You give one person a drug, they respond very well, the depression is gone, they are symptom-free, they go back to work. You give this next person the same drug with the same dose, it doesn't touch them, doesn't do anything, they may even have a side effect, and they go home. So that's, worse than when they first saw you, because now they have a side effect. So what is that, How is that happening? And one example that I feel almost afraid to say this in front of Jeff here, but one of the examples that some people say, it's the same genes, not necessarily. Because let's say if schizophrenia could be caused, and some people have believed that, I don't know if it's the truth or not, that it could be involved in schizophrenia if you have abnormal migration of neurons during development. There is no drug you're going to give in adulthood that's going to make some neurons migrate back to where they should have been. So what caused the disease in the first place and what the drug is doing in adulthood can be very different things. So here, psychiatric treatment is a guessing game. You have, for all of our diseases, these very heterogeneous groups of patients. You give the same drug. For some, the drug is toxic but beneficial. For other people, it's toxic and not beneficial. For other people, it doesn't do anything. And for other people, it's not toxic and beneficial. So can you do genetic testing and identify them a priori before you give the drug? So you give the drug to this person, but not to this one. So in that grant that I got from NIGMS, we did a small study, very small but by today's standards, but it was 300 patients all in our clinic. And I'm a little bit skeptical of this very large, these multi-center studies. I mean, if you do a multi-center study and have huge numbers of people, all the power to you, but I don't think there is a rationale to do multi-center studies of common disease to get I saw a paper once in the archives with 200 patients in depression, 10 centers. You don't need 10 centers to study 200 depressed people, and then you have all the variability across the center and inter-rater, and, it's a mess. So we studied 300 patients at UCLA ourselves, without having ever done anything like that before. So the idea then, we got 300 controls from the same population. They were all Mexican-American. We did a single-blind placebo-leading with either desipramine or fluoxetine. And then we did a number of studies. So that's the template we've been using for 20 years. So we drew the phenotype, the genotype. Initially, we did candidate systems, then we searched for new targets, and the goal is a clinical translation and looking at ethical implications. So the phenotype, of course, is antidepressant treatment response, so measured by the Hamilton scale. And, the MADRS could be a little better, but that's what most people have been using, so we just stuck with the HAM-D. So here is first people here are in complete remission, and here they are still depressed, so I think this variability could be in part due to genes. So you have specific candidates, and a lot of people test, different genes, and they say, I had this hypothesis here, but, bogus hypothesis. They test a bunch of things, and whatever came out positive, then they came up with a hypothesis. But I'm not going to get into that. But here I really had a hypothesis. So my wife was the first to localize a CRF receptor 1 in the brain. It was discovered by Wiley Valo's group in '94. In the same year, she localized. As soon as the cDNA was published, she created the probes and did the mapping and published it in endocrinology. So look at the dates. That was '94. Then we published in 2004, 10 years later, the first association of, in this case, was antidepressant treatment response with CRH receptor 1. But at that time, many of you were around, some of you were not. There was a huge interest and focus on CRH. And I find it absolutely astonishing that everybody's studying CRH and CRH mutations and CRH gene. And the gene, the peptide, the gene encodes a peptide. The peptide binds to a receptor. So the action is mediated through the receptor. So in 10 years, nobody went from looking at from the receptor's discovery to doing any type of genetic association study related to the receptor, which we did 10 years later, and we are the first. And now there are over 60 published association studies with this gene. But sometimes it's not rocket science, So then we developed an approach which became very common later on, which is to look at not only one SNP at a time, but at that point you could not do whole genome, but you could do hundreds. So we said, okay, why don't we do these hundreds around a specific biological pathway? And then we had a bioinformatician who would put those genes, the pathway together, and then look at all SNPs in that pathway, and then we would, genotype them. And so I'll talk about the pathway that has been of great interest to me, and I began studying it in 1986 or 7, and which is the immune pathway, cytokines. And so cytokines are very important for the regulation of mood. And the initial question in that field was whether they were made in the brain. So we showed that they are. So there is the hypothalamic pituitary adrenal axis that I talked to you before that regulates the endocrine component of the stress response, but that axis is very tied up to immune regulation, and immune regulators by themselves can regulate CRH. So it's really a very complex closed loop. So we've been looking at brain cytokines in depression using molecular neurobiology, animal models, clinical research, and genetics. So because of the time, I'll just go through this very quickly here. So we were the first, among the first groups to show that the brain makes its own cytokines. Yes, which we, published a number of papers showing that. We showed that there is a kind of a clinical component, IL-6 goes up peripherally. Then when you do a pathway analysis, you have findings, associations related to inflammation-related genes. I'm going to skip what this has been replicated in animals, so the findings that we have were shown to be relevant in animals. And what we've been doing more recently is doing a whole genome sequencing and developing mathematical paradigms to cluster people based on their entire genetic sequence into whether they have depression or whether they respond to antidepressants. So this work began to come out last year. Cheng Long-Gu, the bioinformatician, has been doing this. And so we've been clustering individuals with major depression using whole genome sequence variance data. And you can see that you can actually cluster them. So this is depression, this is controls, and this is Australian controls. You can do that in the Mexican-American population. You cannot do this in Caucasian, because Mexican-Americans have twice as much genetic variability in terms of variants, including rare variants, than Caucasians. So Caucasians are genetically impoverished, and you cannot show that kind of clustering. So we had a number of papers showing this, and Hugh Ott wrote an editorial commenting, very positively commenting on it. And one last thing I'd like to show here is that we've done an approach looking at looking at a hierarchical analysis of genetic variants and environmental factors. And we got a grant in Australia to continue to do this. And I'll skip this paper here, it's a little older. So what we found here is that there are some genes that segregate with depression, and what we have focused on now, there are many findings that have come up in genetics these days, and some of them may be artifacts, some may or may not replicate, but I think regardless of the replication issue, if you show that your finding is relevant to brain function and contributes to more or less like the work that you did in leptin, that it contributes, let's say, to regulate the stress response, and it's dysregulated in chronic stress, I think that helps us elucidate the biology more than what we've done so far. So our latest finding, which is this PHF21B gene, is that it's associated with depression, but it's also a modulator of the stress response. So if you look, I didn't put the data here, but if you look at the animals that were chronically stressed, some are actually resilient. So you do the chronic stress, and they don't behave depressed. And those had this gene overexpressed. The product of this gene was overexpressed. So I think that our latest direction is to go from genetic findings to biology. So this is my last slide here. So the way that I conceptualize our own work in the field is that you have changes in the brain. You go from defined functional changes like what you have in Alzheimer's, for example, the plaques and the tangles, or what we have in other diseases should be discovered or should be confirmed microstructural functional changes with alterations in key functions. And then, how do you approach this? You can do vertical or horizontal integration. So vertical integration, you go disease by disease, and you look at cells, include iPSC cells and animal models and first-in-human studies, clinical trials, new treatments, and improved outcomes, hopefully. And then you can approach these diseases horizontally. So you can get a shared biological process, could be inflammation, microbiome, or neuroendocrine changes, or technical approaches like iPSC or imaging or genetics, and then study a number of diseases, using the same approach. So you can approach these difficult conditions either in a vertical manner or horizontally. And that's what we're trying to do, a combination of both. Thank you.
Wow, Julio, that's a massive amount of work, and I mean, almost as many data points as miles you've traveled in the course of your career. So leave this slide, just referring to this slide, that I think is a very instructive and useful sort of framework to approach. But within those disorder categories, you've already alluded to the likely extensive heterogeneity in terms of etiology and pathophysiology. So, are you saying that that'll be dissected in the course of proceeding with this vertical integration analysis, or that there needs to be some way of distinguishing between various pathophysiologic subtypes? I mean, for example, the study that came out recently by Sage Therapeutics using allopregnanolone for postpartum depression, I mean, assuming you believe it. Dramatic effect. My first question, is it replicable? And then the second is, does it generalize beyond postpartum? So, at any rate, to the heterogeneity issue.
So that's a very important question, Jeff, and really key. So the way I think about this is that I think it's better to study smaller groups of people who are very well characterized than larger groups that are more heterogeneous. So I think one way to do this vertical integration is to do it in very well characterized smaller groups of patients. So for example, we talk a lot, and I mean the immune hypothesis has been going on forever, way before me. So it's 30, 40 years, but I haven't seen any studies that people get large numbers of depressed people and then stratify them, because some people you can measure, immune function, cytokines, and do stimulation tests, and some will have changes and some won't. And then you get the people who don't have changes and the ones who do, and then you do separate studies, imaging or genetics or other things. And the same thing could be true with even something as simple as endocrine stimulation. So some people have HP axis stimulation, other people don't. But you just notice that. But then as you do your treatment studies or biological studies or imaging studies, you tend not to stratify people based on these defining features. But I think you should, but I'm just saying that that's how I think you should go in the future, is by looking at very well characterized and groups of patients that have the same features.
Bill?
Thank you very much for a wide-ranging talk. Dr. Licinio, you mentioned that some of our treatments haven't changed in 40 years. Here's a 40-year-old drug effect question. Could you give us any update on what it is about psychotropics, antidepressants and others, that cause weight gain? Do we know more about it than we did 40 years ago?
I don't think we do. There are people who have been doing pharmacogenetic studies, so there are some genes that are variants that are associated with the weight gain, but it's not like a cause. One thing which I think, and it's a little bit of something out there, but my ideas are a little bit out there anyway, which is that there is this discussion that there is an overlap in the brain between the pathways that regulate mood and the ones that regulate food intake. And that's why the two things are so close together. I actually think that some of these pathways may actually be one and the same. So I think it's the same pathways that are regulating mood are regulating food intake. And it's going to be, if that's the case, it's going to be nearly impossible for you to just, get a drug that then affects mood without affecting, body weight, because it's the same pathways. So I actually think that the issue is that the pathways that regulate mood, not that they are in proximity or have some, neighboring, tension with the ones that regulate food intake. I think that some of them are the same, and then you can't affect one thing without affecting the other.
Yes, back here.
Have you considered the microbiome as a factor that would affect different people responding differently to the drugs?
Do you know something? I had another version. Remember that I was, fighting with the different versions of the stock? I have, hold on 1 second. Here. Yes. I had another version that had a whole line of study that we're doing on the microbiome. Yes.
Affect the immune system and
Yes.
the affect.
So we have actually a few papers on this, and another one that's has not been submitted. I hope it will be in press. It's in preparation for submission, looking at the interface of microbiome and mood and immune mediators. So, so in this paper, which was done with collaborators in China, they gave stools from depressed patients to germ-free animals created in absolute germ-free conditions, and the recipient animal behaves depressed, and not the ones that receive normal stools. And then we did this looking at the interface of inflammation and microbiome as relates to mood. And we think it's part of this is mediated by caspase-1, which is an enzyme that kind of triggers the immune response. And in the absence of caspase-1, you don't have depressive-like behaviors, and you have a different microbiome. So it's a very important area to me, but I could only present so much, so I skipped this part. And the other version I was hesitating because the other version had this data, but was longer, then I would still be talking. So I took it out. But I'm so glad that you asked the question, because I think it's a key, kind of a area where, environmental factors interface with the microbiome and with the immune system affecting behavior. So, and just for you to know, I visited here in New York recently, like a few months ago, a person who I think is the most successful person in research in the country. Her name is Nancy Thornberry. So she discovered caspase-1 many years ago, and then she worked at Merck. And then she, what did she do then? Then she created a drug for diabetes, Juvendi, that I can tell you later how she came about. But it's a very intelligent way that she designed the drug and to do something that nobody else was, exploring, and then became the only new treatment for diabetes in 10 years and brought Merck billions of dollars a year in new revenue. And then she left Merck and set up a biotech here in New York City, in Manhattan, near NYU, and got $44 million in venture capital. And the only focus of a company is to look at the interface of a microbiome, inflammation, and behavior as a target for new treatments for depression. So that's the most successful medicinal chemist in 10 years. And so it is a very important area, and I think it's probably where some, and her rationale, which I think is very valid, is that to deal with depression effectively, or to deal with brain disorders, you probably need to affect more than one pathway. If you just give just one drug affecting one target, some people respond to simple antidepressant, but that's, the patients that we see, the more complicated patients, they are on a number of drugs. And so you have these cocktails that are done not very scientifically, and then they have very, different interactions and side effects. It's like a mess. So she thinks that if you, in terms of the microbiome, you could affect multiple targets and multiple microbes and do multiple levels of intervention without the central nervous system side effects. And so she thinks that modulating the microbiome would be more problem-free than modulating the brain directly.
Yes,
So that's the rationale.
Yeah, go ahead.
Yes. the concept of a magic bullet, let's say, for syphilis or for bacterial diseases is one thing. And let's say they have issues like alkaptonuria or hemochromatosis or porphyria, when we're dealing with pathways that are simple compared to the brain. Now, I happened to meet Jeffrey Friedman at the time that he discovered leptin. He felt this would solve all the problems, and it's nowhere near. So let's say in terms of the problem of obesity, which you addressed,
Yes.
how rare is leptin deficiency, and what application have we learned so far that helps the obesity problem? The brain is more complicated with, 3 billion base pairs and 1 million errors.
So the leptin deficiency, it's 29 people in the world. Those 4 patients plus 25 others. So it's not too many.
Yeah.
So to the point that there was a question in the field out there that maybe what Jeff Friedman discovered was very important for biology of rodents or for something else, but it had no relevance to human biology. So the work of, the people who are studying the other patients, they've, Stephen O'Reilly in Cambridge had shown results in humans. We showed results in humans. So we show at least that this pathway is relevant for human biology, because without leptin, you see what happens. So it is a pathway that's relevant to human biology, but it's not very applicable to treating obesity. So one discovery that I think was made that is interesting, and I don't know why it hasn't been explored further, is that, as you know, it's very difficult to lose weight, but then once you lose the weight, most people regain. So if you get people into these very intensive weight loss programs and then you treat them with leptin intensively, they are less likely to regain the weight, which is not huge and it's not like a blockbuster thing, but I think it's a meaningful thing. So maybe the role of leptin could be to prevent people from regaining the weight. And the other thing is that, yes, in humans there is this very strong leptin resistance. But what people are doing is try to understand that resistance at molecular levels and then trying to develop new drugs that would not necessarily, deal with leptin or its receptor, but try to decrease the level of resistance. So I think it has given us some hints, but has not been the promise, that people thought it would be.
So why don't we take the questions upstairs for lunch? I want to say thank you again for a wonderful talk and invite everyone for lunch to continue the discussion.